My name is Mark Blount. I'm a pharmacist prescriber from NHS Dumfries and Galloway Specialist Drug and Alcohol Service. And today I'm going to look at the strategy of us using microdosing to transfer from methadone to buprenorphine, which, as we know, can be quite challenging at times for our patients. Just a snapshot of Dumfries and Galloway. We have 50 staff in our multidisciplinary team, which is a psychiatrist, junior doctors, mental health nurses, general nurses, pharmacists, pharmacy techs, and healthcare support workers, some with lived experience, and also have an OT, and thankfully soon we'll also have a psychologist on our team as well. Two main hubs, Dumfries and Stranraer, and the area is split into 4 localities. Just a bit of background, why? Obviously methadone was the drug of choice for prescribing an opiate replacement. I remember going away back 1990, I think it was, in Dumfries and Galloway, but I was fresh out of university, and the Drug and Alcohol Service started prescribing methadone then. And actually I'd gone away for 4 years to Edinburgh and come back, and unfortunately some of the patients that I had that came to our pharmacy were some of the lads that I was at school with. And it's heartbreaking to see now some of these lads are still on methadone. I met one last week when I was down at the pharmacy. So, as I say, over 30 years they've had this methadone, the liquid, handcuff the prisoner to the medication. So we have got treatment options, and we're now, obviously, with MAT Standard 2, want to give better choice. And as we know, buprenorphine has been a drug that's been available for quite a number of years, but wasn't prescribed as widely because, I say, we were prescribing methadone. But we know buprenorphine is a safer drug for our patients to be on. We did a deep dive into our drug-related deaths recently, and the patients we have in service, far more are dying with methadone in the system prescribed rather than buprenorphine. So we know if we can get the patients on buprenorphine, it's going to stop drug-related deaths. So the conventional direct transfer method from getting people from methadone to buprenorphine, we used to have to take them down to 30 mils, and then we stopped them, and then maybe a 48 to 72 hours so they could go into withdrawal and then start the buprenorphine. Because if you started the buprenorphine too early, because it's higher affinity for the receptors, it knocks the methadone off and can put patients into precipitated withdrawals. And so this is not what we want. And so, but it is challenging. So if you've got somebody on methadone 80, 90 mils daily, to get them down to 30 mils is difficult. So we came up with a way that we can move people directly from higher doses. So what we do a gradual transfer using small doses of oral buprenorphine at the same time as methadone, without needing this period of opiate withdrawal. It's an adaptation of the Bernice method, which was 2016. So we use buprenorphine 0.4 milligram tablets and Espinor 2 milligram and 8 milligram wafers. It is off-label, but there is a lot of evidence of a safe transition between other opioids and buprenorphine. And its aims is to minimise the patient's symptoms associated with withdrawal from methadone and reduce the risk of precipitated withdrawal symptoms. So our approach, we've got 3 different dosage regimens: 10 to 30 milligram daily of methadone, 31 to 60, and 61 milligram daily and above. And the duration is normally sort of 17 to 21 days, depending on what dose of methadone. And we've altered these dosing schedules since we started it, which was, I think, in November 2021 when we first started it, with patient feedback saying, I think, you're dropping my methadone too early. So we've actually altered the schedules. So we'll go and look at now success rates, the barriers we sort of overcame, and an analysis of ongoing issues. And we've also we devised a feedback evaluation questionnaire, which the patients have been carrying out, giving us feedback. So that's just an example of the schedule if somebody was on 31 and 60 milligrams. So on day 1, for example, we take the patients on 60 mils of methadone. We're increasing the dose of buprenorphine in small doses until we get to day 9, when we'll drop to 40 mils of methadone, and by that time they're on 6 milligrams of buprenorphine. On to day 13, we'll drop to 20 mils of methadone, and by that time they're on 10 milligrams of Espinor. and then day 17 we stop the methadone altogether, and they're on 16 milligram of buprenorphine. Then they've got the choice of staying on the oral buprenorphine or moving them on to Buvidal, the long-acting injectable. So at the time of this presentation, been put together, we've done it with 144 patients. We were successful in 105 and we were unsuccessful in 39. So a 73% sort of strike rate, which we were quite pleased with. Obviously, we'd like 100%, but we thought at 73% was quite good. So just a sort of breakdown of those 105 patients. 82 went on to Buvidal, 21 stayed on buprenorphine, and actually 2 had a successful detox and decided, I don't want any more tablets, I'm happy. So, that was a good result as well. Of the 39 that that weren't successful, 32 went back to methadone and 7 disengaged. 2 of that 7 actually left the region. I think a couple moved to Glasgow. But and the other 5, we've obviously were trying to get them back, and 2 or 3 of them have actually come back into service as well. So as I've mentioned, we've obviously prescribing-wise in NHS Dumfries and Galloway, going back to that 1990, it was obviously 100% methadone. But over the last while, especially the last 18 months, we've really had a move to buprenorphine from methadone. So just now, we're on 39% of methadone in the service, 17% oral buprenorphine, and we've got 44% on Buvidal, the long-acting injectable. Feedback from nurses. We were obviously working closely with the patients. A lot of this feedback was early feedback. The nurses said, I've never had an easy microinduction. Difficulties due arise due to the under-reporting of use on top or polydrug use, whether it be benzos, cocaine. And some nurses felt some patients were still using on top of ORT, and I'll go on to speak a bit about that in a minute. Now, the easy ones to move over were the ones on low doses, and they moved over quite easily, but then we started to work on the higher doses as we got more confidence in the regimen and chatting to the patients. So you're probably looking at less stable and more anxious. And they're sort of looking at everything, sort of withdrawal in the most forensic detail. So it was challenging for the patients. Successful when methadone drops later in induction, and that is why we then alter the regimen. Sometimes we needed to sort prescriptions out for diazepam or zopiclone for a few days to get them over the worst of that. But a big part was the preparation with the patients, actually supporting the patients all the time, being on the phone, make sure when they had those days when they were dropping the methadone dose, they were going to have a stock of food. Just prepare them for maybe a day on the couch, and I'd say just give as much support as possible. Feedback from the patients, fantastic, brilliant, all went well, no issues, adequate support, nervous initially, but surprised how easy it actually was. But when the methadone was reduced by a third, struggled with the sleeping, experienced some sweating, managed the withdrawals with paracetamol. Struggled to begin with, then it was okay, poor sleeping, sweaty, but no problems, better than I thought, felt fine the whole time. And we did find in a lot of patients that it went easy, and it went for a dream for them, so which was a fantastic thing. We also asked them, what was your reasons for microdosing? To transition onto Buvidal, get away from the stigma at the pharmacy, which is a big thing. And, I was a community pharmacist for 30 years before I came in to work for the specialist service, and I did not realise as much how maybe drug dealers as well hang about the pharmacy as well to try and hook people back in. But also, that actually going to the pharmacy every single day and the stigma of people, getting watched and things like that, it's terrible for the patients. So if we can take that away, all the better. And people wanted to get off methadone because they had that fog effect, sleepy. And look at an exit strategy as well, what to change the medication. And again, not attending the pharmacy daily. Because we know that if we can get people onto Buvidal, because we've been using it now for nearly 3 years in Dumfries and Galloway, there is a soft fall from it. If we can get them, reduce their injection and get them to the lowest dose, if they've been on it for a year, they will have that soft fall, and it is easier to get them off rather than, as I say, somebody been on methadone for 30 years. Patient feedback, 100% of respondents were glad that they made the transition, and 12 of them said they needed extra help during the transition, whether that was further advice, increased contact with the nurse, help from friends and family, short prescription of diazepams, and just reassuring from their name nurse. So would you change anything about your microdosing experience? If you could, nothing, everything went smoothly. Wish it had been available sooner. Some said the last drop was too big a drop, maybe making the steps smaller, splitting into 2 steps would make it a bit easier. Everything was okay. I started to feel a bit rough towards the end. Get extra support, sleeping tablets, and some had said it would been good to have my mental health review earlier on in the transition. Any advice you would give others looking to microdose? It was easier than I thought. Stick with it, it's quite easy. Go for it, it changes your life. Always recommend it to people. Do it, it's worth it. Don't let the chat put you off, as it can be intimidating. It's easier than it looks, because obviously we give the patient the regimen chart and we go through it with them. The pharmacy gets a regimen chart as well. We also asked them to map their microdosing experience. So 65% said really good, fantastic, 24% okay, and 12% obviously were more negative for the people who struggle with it. Key learnings: preparatory work is important. Really prepare the patient well and say, let them know. I mean, they obviously know what withdrawals can be like. So, but prepare them for if they're going to have maybe a 2-day flu when that drop comes. Have paracetamol, ibuprofen, Lemsip, loperamide, maybe for diarrhea, Buscopan, Beverine for stomach cramps as well. And really, really important, I have to sort of stress to the patients, try and be honest with the extra use. If they are using heroin or opiates, benzos, pregabs, cocaine on top, that will hamper the attempts. Because obviously, we've sort of scientifically done, increasing the buprenorphine as we reduce the methadone. If you're adding extra drugs into that, that may make them feel unwell. Share successful positive peer stories. One negative story goes a lot further than the 10 positive ones. And it was slow, the uptake to begin with, but actually once the patients started speaking to each other and say, that was easy, we managed to do that okay, then that's when the sort of snowball started rolling. But also, if the patient suffers from anxiety and trauma, the switch from methadone to buprenorphine can be tough, because obviously the clarity they're getting now from buprenorphine rather than methadone. So that may open some psychological wounds. So that's why we need to make sure that support is there for the patient with that psychological help. And just assess the readiness and motivation to transition for each patient. Concluding thoughts, well, we now feel we've got a standardised transfer approach within the specialist service. We've had successful microdosing of many patients, some who have experienced little or no side effects. But key to transition and success of the change is make sure the patient's motivated for the right reasons, that they want to get onto buprenorphine, they want to stop using, work with them, that they've got a clear commitment and a drive for change. But make sure the name nurse has to do that proprietary work for the transition with the patient. So now we've increased the options for choice for transition methods. We've created flexibility, we've reduced potential barriers post the starting buprenorphine treatment, and we're hopefully minimising the risk of precipitated opiate withdrawals and minimising the risk of treatment disengagement. Thank you.